Okay, a pleasant afternoon to everyone. My name is Dr. Kusham Orbia. So my topic for this afternoon will be cancer of the blood. So let's first talk about blood. Minsan pag blood kasi ang pinag-uusapan natin, we often associate it with the term anemia. So is anemia cancer? So no, but it can be a feature or presentation. So some cancers may present with anemia, but not all anemias are considered presentations of cancer. So hematologic pathologies or sinasabi natin cancer of the blood, marami siyang uri. We can narrow them down by grouping them together with the following. We have the most common would be your leukemia, followed by lymphoma. We have your B-cell dyscrasias like your multiple myeloma or even the macroglobulinemia, pero those are rare occasions. And we have your multiple myeloproliferative neoplasms and myelodysplastic syndromes, which are very much rare. But we'll discuss the big three, more likely, because these are the most common types of malignancies or cancer sa dugo na meron sa mundo, kumbaga. No? Start first with this question. Namamana ba ang cancer sa dugo? The correct answer there is yes. Okay. Cancer of the blood can be passed on from different generations depending to the type of cancer. Let's touch the first group of cancer of the blood or hematologic disorders, leukemia. So for leukemia is the overgrowth of blood cells that are usually seen within the blood's source. Kung saan ba nanggagaling? Saan ba na-produce ang blood sa ating katawan? Di ba? Sa bone marrow. So, myeloid cells are usually associated dito sa type of leukemia na to. So, ang myeloid, kapag kinuusapan natin myeloid, these are your immature or premature cells, meaning yung mga original cells na nanggagaling sa bone marrow natin na eventually, kapag nag-mature sila, they form your platelets, they form also your WBCs and your RBCs. So, eventually, kapag nagka-problema ka doon sa myeloid cell na yan, may mga types of myeloid cells na dumadami and nagkakaroon siya ng overabundance because of certain factors sa kanilang environment or sa kanilang genetics. So, quick question, ang leukemia ba ay cancer lang sa mga bata? Correct answer there is no. Kasi leukemia can be seen in all ages. Pag titignan nyo dito sa graph of a demographic landscape of the four types of leukemia in groups, okay, you have your ALL or acute lymphocytic leukemia, which is common among, pag nakita nyo dito, common among children below 10 years of age, sa mga bata. And then, we have your CML or your chronic myeloid or myelogenous leukemia. So this is common on two age groups, the 20s to 30s to 50s and to 60s. So pag napansin nyo, may dalawa siyang peak. Okay, so there is a bimodal higher distribution, kumbaga. No? And then we have your AML, acute myeloid leukemia. Incidence increase when you grow older, okay? And then similar, we have your CLL or your chronic lymphocytic leukemia, which is common also among elderlies and the most common adult leukemia in Caucasians but rare in Asians like Filipinos, okay? So pag napapansin nyo dito, all age groups, meron tayong risk of developing leukemia. Depende na lang kung ano yung mga risk factors na pwedeng mag-drive ng exposure natin to developing leukemia. So, what is acute and chronic? Pag napansin nyo kasi dun sa graph natin, may mga acute myeloid, acute lymphocytic, chronic myeloid, chronic lymphocytic leukemia. So, acute meaning may mga undifferentiated cells. Kadalasan kapag sinasabing acute, ang problem niyan ay mga blast cells or immature cells. Nagsisimula ito usually sa bone marrow. Kapag sa bone marrow, dun pa lang nagpo-proliferate na ang mga immature cells. They often occupy a large space sa bone marrow, making the cells push out mature cells and even to the point na kung wala ng space, naglalabas na siya ng immature cells sa peripheral blood smear. In diagnosing cancer of the blood, we will often do a bone marrow smear as well as a peripheral blood smear. So sa bone marrow, pag nakita natin na madami na ang blast cells, like tingnan sa picture, may mga cells na may nucleus compared to a normal mature RBC na walang nucleus, na donut shape siya. So these are your immature or blast cells. Meron siyang very large nucleus with a scanty cytoplasm. And these are clonal stem cells, no? And then, since may problema sila sa maturation, hindi sila nagpo-progress sa development, dumadami lang ng dumadami yung mga immature cells. Diyan nagkakaroon tayo ng acute type of leukemia. Okay, there is very large or rapid onset of proliferation of abnormal immature cells. Yan ang acute form of leukemia. Now, for chronic leukemia, ito naman, if you notice, ito ay peripheral blood smear. And then, mas madami ang proliferation ng mga mature cells like your WBC count. Kapag kasi ang WBC count natin in a peripheral blood smear, mas madami pa rin dapat ang red blood cells. Pero if let's say, for example, nagkakaroon ka na ng increased number of WBC counts or leukocytes, like mga may nucleus, there is what we call a sudden shift, okay, in the number of white blood cells. Kapag napapansin natin yan, we have what we call either lymphocytosis or increase of lymphocytes. Pag napapansin nyo, these are lymphocytes that are normally seen in the WBC or the peripheral blood smear. Pero pag dumadami sila sobra, even to the point na may mga vacuoles siya and meron siya mga nucleoli, okay, you would notice that these types of cells are also immature. Pero to the point na near maturity na sila. Hindi siya kagaya nung sa mature cells na sobrang laki at scant yung cytoplasm niya. So, dito naman, this is a slower clinical progression, kaya common din itong mga types of CLL among elderlies pag ganitong situation. But you have to take note, the differentiation niya is, if you would look at the peripheral blood smear, there are number of mature cells na dumadami dun sa blood smears like your lymphocytes compare sa acute na mga blast cells ang madami. Now we go deeper dun sa mga groups natin. Talk about your AML, sorry for the typo, that is AML, acute myeloid leukemia. Actually, this is the most rapid and syempre very difficult to manage most of the time kasi kailangan talaga magkaroon ka ng chemotherapy. So, acute myeloid leukemia that will present in adults is a type of cancer in which the bone marrow makes large numbers of the abnormal cell. Again, going back to this image, there is usually the production from a premature cell, your stem cell, blood stem cell, going to your RBCs, WBCs, and platelets. Pero kung hindi sila nagpo-progress, puro stem cells lang ang pagdami, that's what you call a leukemia-like effect. Tumadami na yung mga abnormal cells. To the point na pinupush niya yung mga normal cells out from the bone marrow and then naglalabas na rin siya ng mga blast cells to the peripheral blood smear. So leukemia may affect red blood cells, WBCs, and platelets. Kaya pagpapansin mo sa types ng AML, may mga different subtypes siya depending kung ano yung nagpo-proliferate. So when will we assess that? By means of immunohistochemistry as well as assessing the bone marrow of a patient. So ano mga risk factors ng mga patients to develop AML? So the most common culprits according to the National Studies of Cancer Institute in America, smoking is a risk factor. Okay, aside from that, previous history of chemotherapy can also be a risk factor for AML, and even exposure to radiation. These are significant risk factors that can predispose an individual to produce or develop AML in the future. So kung let's say nagkikimo ka at saka nagkakaroon ka ng radiotherapy for a certain cancer in the early onset of your life, eventually there is a risk of developing AML when you grow older. Yun yung medyo masaklap lang, no? So you have to weigh the risk. Syempre, you're treating for cancer and then eventually you have to monitor yourself if ever you might develop AML in the future. So again, they come from abnormal cells like your blood stem cells. So the culprit here is your myeloid stem cells. So signs of kung kailan nagkakaroon ka ng development of AML, they can be vague but they are more likely blood related. So the development of fever because of abnormal immune response, feeling of tiredness because yung mga lumalabas na cells ay abnormal cells. They don't develop the capacity to transfer oxygen to every part of the body because yung mga RBCs na mature ang gumagawa nun. Ang abnormal cells, they cannot deliver oxygen. Okay, you find yourself to be easily bruising or easily bleeding because you don't produce enough platelets. Since a myeloblast or a myeloblast also develops into a platelet like your megakaryocyte, kung hindi sila nakapag-produce ng megakaryocyte, wala kang platelet. So kung wala kang platelet, you're prone to bruising and also bleeding. Yun ang delikado dyan. So after AML has been diagnosed, you have to check also if the cancer has already spread to other parts of the body because there's a high risk na as an area of the bone marrow, though yun nga nakikita mo meron kang presence of your AML in that particular bone marrow, you have to identify also other areas wherein there is high hypercellular bone densities. Baka mag-spread doon yung AML na cancer. So you have to do a bone scan or a body scan for the presence of AML as well. Okay, sabi ko nga kanina, depende yan sa type of AML or cancer na meron ka. So that differentiates a lot. Marami kasing uri ang AML and treatment can also vary. Okay, so the treatment usually for AML, we do a screening or series of chemotherapy, but that should be addressed directly with a hematologist and a hemo-oncologist. Okay. Aside from your AML, we have your CML or your chronic myeloid leukemia. So CML, chronic myeloid leukemia, again, if you notice this is more on the onset of adults, di ba? And this is highly related sa mga namamana type na cancer of the blood. So it's highly associated with what we call your Philadelphia chromosome. If you have this Philadelphia chromosome, there is a what we call an aberrant break, and there is a sudden change of chromosome 9 and 22. Na nagkakaroon siya ng sudden changes between the pattern of chromosome 9 and 22, forming your Philadelphia chromosome. So if you have this type of mutation, like change mutation, you are at risk of developing CML. So, madaling ma-detect ito, if lalo na, let's say, sa family, meron talagang history of CML in the family, and you have to screen every member of the succeeding generation kung magkakaroon ba ng development. That way, you could target your patient or treat your patient early on, even without the beginning of the symptoms. Mababantayan mo siya. So, early detection can be done by doing your chromosome analysis or your FISH analysis para ma-check mo agad. Okay, so if you have that BCR-ABL1 fusion gene, yeah, you have to be alert and talk to a doctor immediately kapag may mga ganito kang types of diagnosis, especially within your family. Okay, so why is CML important? So the disease progression is often somewhat in a rapid onset, diba? So the progression of your disease on CML would start with what you call a chronic phase, then it will later on move to an accelerated phase. So the chronic phase is a mixture of both normal cell and at the same time abnormal cells in the bloodstream. And then most of the time ito asymptomatic ang isang pasyente. Pero after that 5 to 6 years, okay, they would develop your accelerated phase. Bumibilis ang progression of symptoms that usually is 6 to 9 months after the chronic phase. There is a certain change of cytogenic abnormalities. Dumadami ang mga abnormal cells sa inyong blood. So pag dito, papapansin mo, dumadami ang mga abnormal na lymphocytes sa peripheral blood smear. This scenario would also associate with representation of fatigue, madaling mapagod, or at the same time, splenomegaly, paglalaki ng spleen. Okay? Masakit sa may fluid area ng part ng tao. Now, once the patient surpasses the acceleration phase, you enter what we call the blast crisis. In this scenario, magkakaroon ng shutdown ang bone marrow because the increased turnover of blast cells kasi more on the immature na ang lumalabas. And this can be very much critical in this scenario, and treatment should be directed immediately. Okay? Kasi lumalabas na yung mga blast cells from the bone marrow rapidly. So, especially in this scenario, kapag tumingin ka na sa isang smear, majority of the smear is 30% blast or immature cells. So, treatment should be directed and it should be referred. Lalo na dapat kapag sa early phases ng CML, dapat it should be referred immediately with a specialist, a hematologist or hemo-oncologist right away. Now, we go to the ALL, your acute myelocytic leukemia or acute myelogenous leukemia. So, for acute myelocytic leukemia, the usual presentation dito sa mga bata. What are the risk factors? Similar to your acute myeloid leukemia and other forms of leukemia, chemical presence of benzene can be a risk factor, radiation, and the presence of certain viruses, specifically HDLV or HIV. That's why it's important to screen individuals with these types of viruses. Another would be the predisposition of a genetic susceptibility, like your trisomy syndrome. So again, CML is highly associated with the Philadelphia chromosome. For your ALL, the trisomy syndromes are associated with this type of leukemia. So the presentation for these individuals, these children, often present with anemia, and then the presence of makulani. Okay, so you check the areas wherein there's highly palpable lymphadenopathies, either at the cervical end or sa interregionous ends like your axillary lymph nodes, and even within the area of your inguinal lymph nodes. Okay, aside from that, the patient will also present with more on bleeding and enlargement of certain organs like your spleen and your liver. Joint pains are also presented. So if you look at the peripheral blood smear, there is also increased predisposition of blast cells at a differential count, almost 20%. So maraming types ang ALL. Then, if you notice, That depends on the type of immature cells na nakikita mo. The worst prognosis would always be L2, pag yung napansin nila. Now, finally, CLL, chronic lymphocytic leukemia. For CLL, the pathognomonic feature here would be a smudge cell. So this is usually the presentation of a mature-looking lymphocyte with noted parang nawala na yung cytoplasm niya siya. So it's like a paper na crumpled and then nawala na yung edges niya. So demographically, this is common among elderly of more than 50 years old, and it's more common among males. So highest incidence in Caucasians, and this is rare among Asians. So this is more on the presentation of B cells with the clonal differentiation. And if most of the time, if it's a B cell form of CLL, it's a better prognosis. If compared to a T cell, it has a poorer prognosis, diba? So again, the presentation here is similar with almost everyone: fatigue, painless lymphadenopathies, and then the presence of anemia and a positive Coombs test, usually sa mga ganitong situations. Now, the treatment here, meron naman tayong chemotherapy, and then it's often important to take note that if the patient is asymptomatic, we have to observe this because syempre pag this type of leukemia is often seen in elderlies, it's important that we have to consider the patient's age. Kung kaya ba niya mag-undergo ng chemotherapy and kaya ba niya mag-undergo ng certain procedures like splenectomy and IV gamma globulin interventions. So you have to weigh in the quality of life and discuss this with the members of the family. Kasi most often than not, CLL would require palliative approach kasi it's kumbaga you're weighing in treatment goals versus quality of life, lalo na pag sa mas mga matatandang individuals. Now, moving on to leukemia, the next group would be your lymphomas. There are two types of lymphomas, Hodgkin lymphoma and non-Hodgkin lymphoma. Ang importante lang natin malaman, well, pinag-uusapan ko natin ng cancer of blood. Pero ito kasi, these are kulanit or lymph nodes. So if these are lymph nodes, why are we talking about blood? Now, blood and lymph nodes, because they share common types of cells, like your lymphocytes, they come from the same cell line. Okay, there's the same blood stem cells. And once they are produced from the bone marrow, they transfer to the lymph nodes. Now, kung may problema tayo dun sa mga abnormal lymphocytes, they can either migrate to a certain node and they proliferate in that scenario. Kaya nagkakaroon tayo ng, minsan nagkaka-overlap tayo. Is the patient having leukemia or is the patient having lymphoma? Ano ba nauna? So there's a certain blurring of origin kung ano yung sakit in this situation. Nonetheless, it's important to identify if the patient has leukemia, if the patient has lymphoma, we have to target which of the following, kung ano yung meron sa kanya. And it's often best discussed with a multidisciplinary approach. So for Hodgkin lymphoma, madalas ito yung nakikita naman in patients with the presence of a lymphadenopathy, yung mga kulani na painless. Kapag ginawakan mo, hindi siya masakit. And then the presentation, kapag symptomatic siya, they present with the B symptoms. So usually fever, nangayayat, weight loss, there is night sweats, and pruritus. So pag napansin nyo to, it's often important to identify this situation. Kasi let's say in a clinical scenario, fever, weight loss, night sweats. Tapos wala naman siyang, may sabi niya, scanty lang yung ubo niya. It's a good differential for, let's say, clinical TB. Pero at the same time, wala naman siyang cough or chronic cough. So it's important that you have to take into consideration to do a WBC count to check if there is any abnormality. And then, don't disregard kung marami naman kayo nakakatang mga lymphadenopathies. It's a good consideration to check for a blood disorder like Hodgkin lymphoma. So sa peripheral blood smear, the classic presentation there is an owl's eye or your classic Reed-Steinberg cell. Pag nakita nyo, yun, dalawang mata. So there's two nuclear lobes and a large inclusion nuclei. Yeah. So maraming types ang HL or Hodgkin lymphoma. Ang importante lang na malaman natin is, well, if it's important to take note, kumbaga, is what's the type of subtype that is having a worse prognosis. So if it's a lymphocyte depletion, that is more likely the worst prognosis. The better prognosis for treatment would be lymphocyte predominant kasi meron tayong targeted treatment. Now, it's also important to identify kung ano yung staging ng Hodgkin lymphoma. At this situation, we could stage them according to stage 1 to 4 depending kung nasaan yung mga kulani na nakakapas sa isang pasyente. Now, it's also important to do a full body scan like an MRI kasi may mga areas of the lymphadenopathies na hindi mo talaga makikita. So, like stage 3 and stage 4, you have to identify if there's a periaortal or sa aortic or abdominal na lymphadenopathies present or even in the inguinal areas. Diba? Now, for Hodgkin lymphoma, once we're done with that, we now have your NHL or non-Hodgkin lymphoma. Now, if for Hodgkin lymphoma, most of the time, it's more on the nodes. For non-Hodgkin lymphoma, it's more of extranodal than nodal. So they mostly present with the nets of lymph nodes within the CNS or the gastric mucosa. So for NHL, most of the time, this is a B-cell associated and may targeted treatment tayo. We call it your R-CHOP, the use of your rituximab. It's very expensive but highly effective in treatment. So kung pagpipiliin ka, syempre wag naman sana tayo magkaroon ng lymphoma, but these are usually the types of lymphoma na pwede may mga possible treatment tayo. And take note that this type of lymphoma is highly associated with certain types of viruses like your Epstein-Barr virus or human T lymphocytic virus 1 and even HIV. Okay. Now, going to the third type of blood or cancer of the blood would be your B-cell dyscrasias. Associated there would be your multiple myeloma. There's a triad there. Mas common na makikita kapag may patient is highly suspicious of multiple myeloma, highly sus. Elderly, okay, most of the time beyond 60, most common among males with the presentation of low back pain because of lytic changes sa my spine or magkakaroon siya ng pathologic fractures. Pag in-x-ray mo, parang durug-durug na yung cervical spine or even in the rib cages because of chronic back pain. Okay, pathologic changes. And then the presence of anemia that is severe but normocytic, meaning normal ang RBC size and normal din ang hemoglobin levels niya. Okay, so yung size niya does not shrivel like an iron deficiency, pero there is a lack or this decreased number of cell number or cell count kumbaga. So the problem here, there is expansion of plasma cells. So pag pinuusapan natin plasma cells, these are the cells na produce antibodies. So monoclonal multiplication at the bone marrow. So may mga abnormal cells tayo na nagpo-produce ng abnormal antibodies and they can cause disruption and destruction ng mga bones or buto. So the secretion of immunoglobulins causes hypergammaglobulinemia na pwede mo ma-assess through electrophoresis as well as checking for the presence of your hyperviscosity syndrome with the presentation of dizziness, vertigo, and hypercalcemia. So prognosis, that depends. Okay, that depends also with the etiology. It's important na meron kang referral directly, timely with a hemo-oncologist and a medical oncologist, multidisciplinary approach. Because at this stage, matanda na siya. Or maganda rin i-refer din to with palliative care. Okay? So for the diagnostic for multiple myeloma, it's important that we do a serum and blood analysis. Sabi ko nga, there is the presence of clumping because of the antibodies. They can cause somewhat of a pseudo agglutination. Baka akalain mo mayroon kang positive Coombs test pero hindi naman pala. Okay? They would also present with the increased number of proteins that would present with hypergammaglobulinemia. So you have to identify what type of IgG or immunoglobulin is high. And if you do electrophoresis, we have an M spike present in almost 8% of cases. Classic sa X-ray, pag nakita mo, lytic, meaning durug-durug yung, or there is noted na punch holes, no? May mga butas, meron siyang, na cookie cutter, either in the spine, and there are some instances kapag nagpa-X-ray ka ng skull, meron siyang mga parang may butas-butas din sa may skull area. So, that's a classic or punch-out lesions seen on X-ray on patients with multiple myeloma. And they are they are prone also with pathologic fractures. So kung spine ito, they're prone also with spinal cord compression. For the bone marrow, there's a proliferation of plasma cells with plasmacytosis. Okay, so plasma cells, again, these are cells that are the ones producing your antibodies. And then for urinalysis, you do your Bence-Jones proteinuria. So if these are aligning, you could easily diagnose multiple myeloma. Again, This is a final overview of the tips of your lymphoid versus your leukemia na lymphocytic. Kasi most often them not, they are presentations seen in almost all age groups. Si myeloid, again, yun mabilisan kasi siya, dapat magamot mo siya agad. Now, what's the clinical takeaway kapag may mga cancer of the blood? It's important that you need to understand the hereditary consideration. Kung meron kang kamag-anak na may sakit sa dugo, you have to identify it. And then you have to advise every generation to get tested para ma-identify kung if you are at risk of developing this type of leukemia or lymphoma, maunahan mo na siya. So, the problem now there is if there is financial capabilities for members of the family to screen them. Kasi most often, kapag nag-present na yung mga pasyente, they present with the types of crisis, nagkakaroon na ng increased turnover of immature cells, and doon na nagkaka-problem with financial struggles because mahal ang gamutan. And often, kapag mga ganong situations, they often flock to government hospitals like CVMC here in Turicaran. Okay, pero treatment, depending on the type of cancer, there are available treatments. Okay? And most often na naman, kapag ganyan, they are often referred also for palliative care para lang din mag-guide sila on decision making. So, family medicine specialists are often associated or partnered there para lang din mag-guide sila in decision making, as well as if ever may mga questions ang mga specialists like your oncologist or hematologist, hindi maintindihan ng family members, we are there to process the information and help them understand to make a more sound decision for the family members. Okay, hopefully this is not too overwhelming of a topic, and if you have any questions at the end of the presentation, feel free to message at the end of this slide. Again, this is Doc Chris, your presenter, and good afternoon everyone.